We're talking about hypoglycemia in malnutrition. This is defined as blood glucose level of less than 3 millimolar. The predisposing factors to hypoglycemia and malnutrition. First is that there is reductive adaptation in malnutrition, so the body is not able to respond as it should normally do. So there are low glucose levels, and this means the patients are prone to hypoglycemia. They cannot produce enough glucose for themselves, and any infections will then tip this into hypoglycemia. Any delays in feeding would tip these patients into hypoglycemia, and any hypothermia would tip these patients into hypoglycemia. We usually say that hypothermia and hypoglycemia are in the same WhatsApp group, and by this we mean that hypothermia can cause hypoglycemia, whilst hypoglycemia can also cause hypothermia. This is because if the patient is hypothermic, then the body has to raise its basal metabolic rate to try and generate heat, and by doing that it then uses up more glucose, and it then goes into hypoglycemia. So if you're hypothermic, you're then prone to, if the patient is hypothermic and is malnourished, then prone to going into hypoglycemia. And we know that if the patient is hypoglycemic, they also develop hypothermia because they are failing to generate heat. So that's why we say hypothermia and hypoglycemia are in the same WhatsApp group. Okay, so features of hypoglycemia in malnutrition. The first feature is the hypothermia, like we said from the WhatsApp group. They're in the same group. So hypothermia, we define this as oral temperature or rectal temperature less than 35.5, or an axillary temperature less than 35. Okay, the other features of hypoglycemia in malnutrition is convulsions. Then the patient can be lethargic, and if the patient is unconscious or is sleeping, their eyelids won't be touching, so there will be partial opening of the eyes, so eyelid retraction will be seen. Then the reductive adaptation means that these patients have no sweat response, so even if they become hypoglycemic, they will not be sweating. So for management of hypoglycemia and malnutrition in a conscious patient, we want to give 50 ml of 10% dextrose IV. This is, we usually give IV or orally, depending on whether the patient is tolerating oral feeds. If the patient is vomiting, we give it as IV fluids. If the patient is tolerating oral feeds, we give it as oral feeds. We give we could give it as 50 ml of oral 10% sucrose. Then just after that, we start giving F75 at 3 ml per kg per feed every 30 minutes for 2 hours. Then we switch to 11 ml per kg per feed every 2 hourly for 2 days. Okay, so like we said, the glucose or sucrose solution should be can be given orally. Then we want to correct hypothermia, so we want to put the patient in a warm environment. We want to make sure that the patient is adequately clothed, and we want to avoid any heat loss. We put the head on the patient, and then we treat any underlying infections. This is to avoid this is to correct any factors that can make hypoglycemia refractory. So underlying infection can make hypoglycemia refractory, so we want to treat that, and we give IV antibiotics as soon as possible. So to prepare the fluids, 10% sucrose is made by mixing 1 rounded teaspoon of sugar with 3.5 tablespoons of sterile or boiled water. So the teaspoon is 1 rounded, so 1 rounded, it means it's full. Okay, it's a rounded, that's full 1 teaspoon of sugar and 3.5 tablespoons of sterile water. Then 10% dextrose is made from 50% dextrose. We normally have 50% dextrose in hospitals, and we take 1 part of that and mix with 4 parts of sterile water. Management of hypoglycemia in malnutrition for an unconscious patient. We start with IV fluids 4 to 6 ml per kg of 10% dextrose start, then 50 ml of 10% glucose or sucrose per nasogastric tube. After that, we then immediately give F75 starter feed per nasogastric tube. Okay, we expect the patient to become conscious after this management. and we then proceed with management as per conscious patient. Then if the patient remains unconscious, then we'll. So this is just a table or a diagram to show the management of hypoglycemia and malnutrition is done. So if the patient is conscious, we start with IV fluids or oral fluids, 10% glucose 50 ml, then move on to oral 3 ml per kg every 30 minutes for 2 hours. In an unconscious patient, we start with IV fluids, 10% dextrose 4 to 6 ml per kg, then move on to the 50 ml of 10% dextrose or sucrose per ng tube. Then we start feeding F70. The monitoring of the patient, will repeat glucometer, finger prick, if we see signs of hypoglycemia. So if the patient becomes hypothermic, that's a sign of hypoglycemia. We have to check the glucometer. And if the patient is deteriorating or the level of consciousness is dropping, we have to check with glucometer again. But if the patient is responding to treatment well, then we have to check the glucometer after 2 hours from the initial one, because we expect a rebound hypoglycemia at 2 hours. If glucose falls to below 3 in any of these readings, you repeat 50 ml of 10% dextrose or sucrose and continue feeding every 30 minutes until stable. Thank you.